All right, we'll come back to you, Dr. Balram, later on.
Yes, sir.
And this is first, you have reasonably done a good job. I must tell you that. Now, my next question is Dr. Vasudev Utpat.
Good evening, sir.
What are the structures in relation with papillary muscles?
This is interventricular septum at arrow. Anterior septum.
This is anterior septum, this is interventricular septum. You got confused a little bit. Then this. Quick, we have 30 seconds to give an answer. Vasudev, what is this? Are you able to hear me, Vasudev? Dr. Vasudev. Okay, let me move on to Dr. Tushar. Dr. Tushar Charkha.
Yes, sir.
Tushar, what is this view is?
This is paraspinal short view
At
papillary muscle level.
Why do you say it's papillary muscle level?
We can see those two papillary muscles where your cursor is moving.
What is this papillary muscle is known as? Name of the papillary muscle and this papillary muscles.
Hello.
Be able to.
Dr. Tushar.
Sir.
No idea. This is anterolateral. This is posterior medial.
Okay. Anatomically, yes. Yes, sir.
Anatomically, yes. What is this segment?
Is anterolateral segment.
Not anterolateral. Anterior septum.
Anterior septum. Sorry. Yes.
This.
Hello.
What is this septum? This is what is this segment?
This should be.
तुषार नहीं पढ़ा आपने बिल्कुल भी.
Sir, mid septum.
Mid septum or septum?
So this should be mid septum.
Okay. And this?
This should be mid lateral.
Opposite septum, what is the wall? Lateral. And wall. This segment?
This should be posterior segment.
Okay. This?
Should be anterolateral.
This?
Inferolateral.
What is the importance of this view? Why do we look this view in clinical practice?
So that we can understand the contractibility, and at the end, if we are looking for the segment-wise ejection fraction, so we can understand how much is the ejection fraction. And again, when we say that the patient had myocardial infarction, so we would be able to localize which vessel is the culprit vessel where the thrombus might be.
No, the answer is it helps you in identifying the various wall segment abnormalities in the mid segments. These two papillary muscles tell you that we are in mid segments of L. But reasonably a good answer, not bad. Thank you. I'll go to the next person. Dr. Tiam, are you there? Dr. Ghansham Motisaria.
Yes, sir.
Ghansham, identify this view.
Sir, this is short axis view at mitral level.
It's written mitral over here. That's why you're saying mitral.
This is confusing. There may be papillary muscle.
Correct.
Papillary muscle.
It is a papillary muscle, man. It's not mitral.
Yes, yes. It is papillary.
Don't look at this answer on left hand side.
Okay, okay.
Okay. Tell me
anything
what is,
else, sir?
No, I'm just asking. What is the structure over here?
This is RV.
And what is the importance of the septum in relation to LV RV?
Whenever RV pressure is high, then this septum will bulging or flattening.
RV pressure high means systolic or diastolic?
Systolic.
Systolic pressure high.
Yes.
So how can you say that systolic pressure are more than RV systolic pressure is more than LV systolic pressure?
During systole, this IVC is tightening
This IVS will flatten and bulge
Yes.
towards
and bulging toward the left ventricle.
LV, and
LV, yes.
suggesting that with systolic contraction, the RV pressure will become more than LV systolic pressures.
Yes.
Right?
Right.
Okay, suppose you don't see of these two papillary muscle, either this is not seen or this is not seen, following some insult. What is that insult is and where the papillary muscles are?
Maybe this is you are talking about parachute.
That is congenital.
Uh,
That is congenital. Good. Suppose you had chest pain, you had a patient
Okay.
who had a chest pain, and you could not
Okay.
see one papillary muscle.
Okay.
What does it imply?
That means that whichever papillary muscle is not seen or not contracted, this is ischemic.
Pardon?
Maybe due to ischemic disease.
That is known as papillary muscle rupture.
Okay. Okay.
You will see over a period of time when some like this is lateral, this is medial. That's how I say. Anterolateral
Yeah.
is involved. When you have significant circumflex territory infarctions, so sometimes these papillary muscle are being unhooked or they are being ruptured from a basis.
Okay.
And in short axis, you will not find any papillary muscle in that. So either it could be parachute mitral valve or it could be a ruptured papillary muscle.
Rupture.
And that is a catastrophic condition requiring emergency interventions. What is what will be the catastrophic condition in this patient if you can't see a papillary muscle?
Maybe this is massive infarct or
Massive infarct along with severe mitral regurgitation. If there is no papillary muscle, only one papillary muscle, their mitral valve leaflet will not co-opt with each other, give rise to severe mitral regurgitation. And these people, they present with not only chest pain, with acute decompensated left ventricular failures, where LA is not able to bear the insult. Like it's like suddenly somebody has got a severe mitral regurgitation. So LA is not compensated at all.
okay.
Right?
Right.
And that kind of a situation, only answer is immediate intervention. All right, good questions, good answer, good answers, both. Ghanshyam. I'll move to next person. Thank you very much.
Sir,
Yeah, please go ahead.
sir, my turn. Actually, net got disconnected. Question.
Dr. Vasudev Utpat.
Yes, sir.
Okay. Short axis view at this is what these segments are. What is this view, Utpat?
This is a
Don't look at this.
three-chamber view. It's LV with aorta, and this is LV cavity, LV base. This is apex, LV apex. This is three-chamber view. It's an infralateral wall. Anterior septum. This is aortic wall, LVOT aortic wall.
This is not aortic wall, this is mitral valve, man.
Oh, that too, sir. Yeah, mitral and lateral side. That will be the aortic.
Correct. And what is this?
That will be RB, sir.
What is the blood supply of this particular segment?
LAD first part before diagonal.
First diagonal, not before diagonal, first diagonal. This is second diagonal, right?
Yes, sir.
And blood supply of these?
That will be the LCX or RCA territory, depending on.
Why LCX and RC territory? Because dependent on what?
Dominant artery. It is. PDA is coming from right side.
Dominant, yeah, dominant artery. Good. Okay, thank you. Now I'll move to next person. Dr. Damodar Swapnil.
Yes, sir. Yes, sir. Good evening.
Damodar, good evening. What is this segment?
So that is the lateral wall, sir.
This is what view?
This is the apical four-chamber view, zoomed.
This is the apical four chamber.
Yes, sir.
This is what? Say this is two chamber view. What is this segment then?
So if it, pardon me, sir, if it is a two chamber view, then it becomes the anterior wall. And that becomes the inferior wall.
Now segment wise, why do you say this is inferior? I say it's posterior.
So inferior and posterior, I thought they are the same nomenclature means.
Okay. Now we'll go to the next person regarding that. Meanwhile, any difference between inferior and posterior wall?
Papillary muscle.
Papillary muscle inside.
Oh, you don't have to. Please. Let him. He's not going to, like, his patients are not going to come to you for examination, man. He has to deal with his own patients. So what did you hear, Dr. Swapnil? What did you hear?
No, sir, I
What?
don't have the answer of that.
Okay. The answer is, whenever you have a papillary muscle, this is always inferior wall. If you can't see a papillary muscle, this is the posterior wall.
Okay, sir.
Blood supply will vary. Inferior wall will be supplied by predominantly RCA. Posterior walls can be supplied by either by RCA or
LCX.
circumflex.
LCX.
Circumflex.
Okay. And that will be the LED, anterior wall.
Anterior wall would be whole LED.
Yes.
Yes.
The
Good.
apex and the upper part of the inferior wall.
We don't say upper part. We say apical inferior, mid
The
inferior,
apical inferior.
apical inferior, apical anterior, mid anterior, basal
Mid
anterior.
anterior and the basal anterior.
All four segments in four chamber view, two chamber view are supplied by LED. This is supplied by RCA.
RCA.
Right?
Okay, sir.
Okay, thank you. Next, I'll go to next Dr. Rahul Kenkal.
Yes, sir.
Rahul, you have got the segments are sitting over here. They have been labeled already over there. Now tell me the segments.
So this is a apical four-chamber view. We can see the anterolateral wall, the inferoseptal wall. The segments we can see is basal anterolateral, mid anterolateral, apical anterolateral, apical cap, apical septal, mid inferoseptal, and basal inferoseptal. You can also see the RV.
First of all, tell me what is this segment is.
Sir, mid inferoseptal.
Yeah.
Basal inferoseptal. Mid inferoseptal.
Rahul, what do you see over here?
Hello. Sir.
What do you see over here?
So the mitral wall.
This is aortic valve, man. Anyway, if this is aortic, what is the segment is known as?
Infero.
This is anterior septum, man.
Anterior septum. Okay, sir.
Rahul, spend time on reading. What is this wall?
RV free wall.
RV free wall supplies derived from
Right coronary artery.
which branch? Right RV branch of the right coronary artery, which arises from a proximal segment itself.
Yes, sir.
And this is what lateral wall is. Lateral wall supplies, can you say the supply of basal lateral, mid lateral, and apical lateral? What is the supply of mid and basal and apical lateral?
Sir, LED, basal. Sir, basal and mid will be LCX. Apical lateral wall will be LED. Apical cap will be LED.
Okay. Reasonably fine, but you have to work hard, Rahul. I'm not really convinced with your working. Okay.
Yes.
We'll come back again. Now this is for Dr. Krishna Yadav. Dr. Krishna Yadav.
Yes, sir.
Identify segments. What is this? Okay, what is this view is?
This is apical four-chamber view, sir.
How do you make apical four-chamber view? Index marker probe where?
Index marker should be pointed towards the left shoulder at 3 o'clock position.
Index marker pointed towards left shoulder.
Yes, sir.
Apical 4 chamber view. And where will you keep the probe?
Probe at the level of apex.
If you keep a probe at the level of apex and the marker is at 11 o'clock position, which view you will get?
Sir, forgive me for this time. He said
Abhijit.
3 o'clock. Sir, he said 3 o'clock.
3 o'clock. Okay.
Yes, sir.
It's fine, Abhijit. Thank you, Abhijit.
Thank you.
Dr. Krishna Yadav, say it again now. How do you make 4-chamber view? Quick. We are not going to spend so much time with you, Dr. Yadav.
Okay.
Tell me how do you make 4-chamber view? Apex, okay, is fine. If you are keeping the cursor at apex, the probe at apex, index marker at 3, 9 or 11 o'clock position. Which position?
9 o'clock position.
It should be 3 o'clock position, man.
Okay.
Index marker at 3 o'clock position, and then you make this particular view. Dr. Yadav, did you make this view at home or not? No.
No, sir.
Okay. Do you have a machine or not?
No, sir, I don't.
Did you read or not?
I have read it, sir, but I don't have.
You read, but you did not make practice. Okay.
Yes, sir. Yes.
All right. That's fine. Thank you. We'll move to next person. This is Mrs. Jigna Vignesh.
Yes, sir. Good evening, sir.
Good evening, Jigna.
Yes, sir.
Since you are doing echocardiography, where do we measure LVOT diameter?
LVOT diameter.
Mm-hmm.
At aortic root, 2 centimeter away from the aortic root.
2 centimeter.
No, sir. No, sir.
You will land up in Delhi, man.
No, no. We are measuring at aortic root only. LVOT diameter.
Okay.
Yeah, in plex view. Parasternal plex view.
What is this view is?
This is a parasternal long axis view.
What is this valve is?
This is RCC, right coronary cusp, and non-coronary cusp.
Why do you say this non-coronary? What does it interfere by non-coronary?
Non-coronary cusp. Right.
What do you mean by non-coronary cusp?
Non-coronary cusps attached.
Non-coronary cusp is known because there is no coronary artery which arises from here, from this cusp. That's why it's known as non-coronary cusp.
Okay, sir. Yeah.
Okay.
Yes, sir.
And this is, what is this structure?
This is the posterior aortic root, anterior aortic root, descending aorta.
Suppose we have one more structure, rounded structure over here.
Yes, sir. Coronary sinus, dilated
Good.
coronary sinus.
Good.
Yes, sir.
Reasonably fine. Jigna, great. Good job done.
Thank you, sir.
Mrs. Jayanti,
Yes, sir. Good evening.
good evening. Ready?
Yes, sir.
All right. Index marker of the probe for parasternal short axis view of papillary muscle.
Sir, it should be, the probe position should be little 1 o'clock to 2 o'clock, and From parasternal long axis to the 1 o'clock position, and we'll get parasternal short axis view of papillary muscle.
How do you get a papillary muscle? How the how the footprint will start looking at? Footprint will look at what?
Footprint should be at right shoulder of the patient.
Right shoulder.
Towards the right shoulder.
Right hip. We move from aorta
yes.
to right hip, not shoulder. Okay.
Okay, sir.
All right. So, and what is the importance of this IVS?
Importance. So to see RWMA.
Interventricular septum for RWMA. Interventricular septum is majority of time used for what? To assess a pressures between RV and LVs. Suppose you have a right side volume overload. How does this pressure behaves like volume overload? They become flattened.
Flat and D shape it will become.
D shape.
Yes.
Remember that everything tells you something in these images, right? We'll come back again. Just don't go away. Abhijit, are you ready? Dr. Abhijit?
Sir, can you hear me?
Yeah, I can hear you. Please ask your next question. Dr. Ranjit.
Sir, I don't have pictures with me.
You can ask the question directly.
Yeah. Dr. Ranjit.
Yes, sir.
Sir, please show the picture.
Okay, shall I share my pictures?
Yes, sir. So, what view is this?
Parasternal short axis at papillary muscle level.
Suppose I see that this is mitral valve level. So why am I wrong?
There is no mitral valve seen here.
And suppose I say it is at the level of the apex. So why am I wrong?
Because there are two tiny structures are seen inside the cavity. These are the papillary muscles.
Okay. And what are the other structures that you can see in this view?
There is LV, there is RV, there is interventricular septum.
Okay. Do you know what are the segments here that are visible? What is that?
Interventricular septum.
No. Yeah, interventricular septum. Then
anteromedial segment.
No. Anterior.
Anterior.
Then what is that?
Anterolateral.
Yeah, and then a little below.
Lateral.
Okay, then
posterior.
Then
posteromedial.
Okay. Now, what coronary artery supplies each of these segments? Anterior and anterior septum is supplied by
LED.
LAD.
Yes.
And the lateral and posterior? Circumflex.
Circumflex.
And the inferior and inferior septum?
RCA.
Actually, PDA. PDA may be from RCA or it may be from left circumflex. Okay, done. Sir, can I examine the next one?
Yeah, next.
Sir, can you show another picture, please?
Yeah, just give me a second. Dr. Ranjit Mohita is there. Dr. Bhatkar Dilip Pandit.
Dr. Pandit, can you hear me?
Yes, sir.
What view is this?
Sir, this is apical 4-chamber view.
Okay. What are the structures that you can see in this view?
Sir, I can see LA, LV, RA, and RV along with mitral.
Mitral valve, and then
yes,
also tricuspid valve.
The tricuspid wall on the right side.
Yeah. Now, suppose I want to see the right-sided structure, RARV. How will I modify this view? In other words, what view is good for seeing the right-sided structure?
Sir, if we have to see the right sided, then we have to shift just one slightly towards mediastinum and one intercostal space below.
No, not below, above.
Above.
Above, one intercostal.
Yeah. And there is yet another way. Instead of shifting, you can just tilt the transducer towards the sternum. That is known as the RV focus view.
RV focus view, yes, sir.
Are you doing echocardiography in your place?
No, sir. Presently, I'm not doing.
You have not handled the machine, right?
No, sir. No, sir.
Sir, can I examine the next
Yeah,
person?
sure. Dilip, if you're not able to handle the machine, what you'll do subsequently?
Sir, I am planning to purchase the machine, but because of PCPNDT, I am not getting.
Okay.
Because I am practicing in periphery. So for that, I require some training certificate, and that's why I'm. Yeah.
I got it. Okay. Next one is Dr. Dinesh Tiwari.
Dr. Tiwari, can you hear me?
Yes, sir.
What view is this?
Yes. Sir. This is a short axis view at aortic level, sir.
Okay, and what are the structures that you can see? What structure is that?
This is aorta, sir. Aortic pulse. This
Yes,
is RA, right atrium, sir, and this is tricuspid wall, sir. This is the pulmonary wall, and this is the pulmonary artery, sir. Right and
so two branches of the pulmonary artery.
Two branches of pulmonary artery. Yes.
Okay. Next person, please.
What is this branch known as?
Sir, this is the right pulmonary artery.
Right pulmonary artery, and this is left pulmonary artery. And this is what?
This is, sorry, sir, I didn't remember this.
Okay. Next person will come up. Dr. Bhimrao Pawar. Bhimrao? B.R. Pawar.
Hello.
Dr. Pawar.
Yes, sir.
Go ahead. You are ready?
Yes, sir. Yes, sir. Yes.
See, suppose I've got a person of patent ductus arteriosus.
Okay, sir.
And I'm looking at this view. So what are the findings that I see here? See, if you know, you answer me. Otherwise, I'll change my question. Don't worry.
No, sir, I don't know.
You have been doing Dopplers?
No, sir. This is my first time online course. I don't know. I'm not.
Have you ever handled the machine?
Just right. Since few days, I am handling it. Since this course has started, I'm handling the probe.
Sir, can we go to the previous picture, please? Previous, yes. See, now this is a 4-chamber view.
Yes, sir.
And somebody comes and tells you that you have to measure the right atrial dimensions. So how do you do that?
Sir, from tricuspid wall to, I mean, the modified we use that modified Simpson method, the DISC method, from wall to wall, right to left.
You trace out the endocardium, right?
Yes, sir. And
valve to valve, and it you join by a straight line or a curved line?
By straight line.
Straight line. Next, what do you do? You take the midpoint of the straight line and join it to the distalmost point. Doctor, you have answered well, but I'll give you marks for this. But tell me, have you been guessing or did you know this?
No, sir. I know. Last to last lecture, you explained this, but I couldn't read it properly. Okay. I just remember whatever.
Suppose I don't want to do modified Simpson method. Is there any other way of assessing the right atrium?
No, sir, I don't know.
Don't worry. Sir, can I have the next person, please? Dr. Gupta, sir.
Yes, sir.
Can I have the next person, please, sir?
Okay. Dr. Pawar is done?
Dr. Pawar is done. He has answered well.
Good. Next person is Dr. Rakshit Bhardwaj.
Dr.
Rakshit,
Bhardwaj, Rakshit, can you hear me? Sir, he can't hear. Rakshit, can
can
you
we
hear
call
me?
Dr. Rakshit? All right. Dr. Ankan Patel.
Yes, sir.
Dr.
Hello.
Patel. Dr. Patel.
Yes, sir. Yes, sir.
Can you see the aorta in the center of the picture?
Yes, sir.
By looking at the aorta from this view, can you tell whether the aortic valve is bicuspid or tricuspid? And how do you do that?
Sir, yes, sir. Sir, it is bicuspid valve, sir. Hello.
When do you say bicuspid and when do you say tricuspid?
Sir, we can see the aortic valve, sir, because it is a cross-sectional picture. So, sir, during the motion, sir, we can see the valve, sir, motion.
So, in which part of the cardiac cycle you see in systole or diastole?
Sir, during the sir, diastole, sir.
No. If you want to tell the morphology of the aortic valve, remember always see in systole.
Sir.
Okay.
Sir.
Dr. Gupta, sir, can you show the next picture, please? See, this is apical fourth chamber.
Sir.
Tell me the names of the wall segments that you can see here.
Sir, the segments of the heart, sir. Yes, sir. Sir,
that can be seen here in this picture.
Yes, sir. Sir, that is the apical segment, sir. Sir, that is the sir inferoseptal segment, sir. Sir, sir, apical segment.
In the apex, is there inferoseptal?
Sir?
In the apex, there are 4 segments. Anterior, lateral, inferior, and septal. So that is septal.
Sir.
Dr. Gupta, sir, can you show another segment, please? What segment is that?
Sir, that is the sir, anterior segment, sir.
Anterior?
Sir, mid-anterior, sir.
You can't see the anterior. That is not in the screen. You are seeing some part of the
sir, that is
lateral,
the lateral,
one.
sir. Yes, sir. Lateral, sir. Sir, apical lateral, sir.
Ankan, what 2 parts of a LV are seen over here? Which this is one part, one segment of the LV. This is second segment of LV. What is this segment is known as?
Sir, that is the septal, sir. Septum.
And what is this?
Sir, that is the lateral, sir. Lateral wall.
Why did you say anterior? Anterior is seen in which picture? Which view?
Sir, in the plaque, sir.
Ankan, read, man, read.
Sir.
Doctor, if you see the plaque, you will be seeing the anteroseptal, not anterior. If you want to have a good look at the anterior, you have to take apical 2-chamber view. You can see the anterior and inferior. Would you remember that, please?
Sir.
Sir, can we have the next person?
Right. Ankan, you're not doing good, man. Improve yourself.
Ankan, a good way is to draw pictures on a rough sheet of paper and to mark and identify the segments without opening the book. You will remember within 1 or 2 days. Who's the next person, please?
Dr. Natin Gupta.
Dr. Gupta, can you?
Yes, sir.
Can you hear me? Yes. So this is a apical 2-chamber view, and you can see the index marker. What wall is that? Can you see the marker?
Yes, sir.
What wall is that?
The mid-anterior wall.
Mid-anterior. Sir, can you move the cursor, please? What segment is that?
Apical interior.
You are right. And what is that?
And
Basal anterior.
Basal anterior. Sir, move it further, please. Then, what structure?
Inferior, basal inferior, mid inferior, and apical inferior.
What structure do you see in the mid and inferior? What do you see there? There is some remarkable structure.
Trabeculation.
It is the
Trabeculation.
trabeculation. No, there's something more important than that. It will come and go during systole and diastole. That is the
Endocardium.
inferior papillary muscle.
Okay.
Sir, can I have the next person, please?
Sure. Dr. Hiru Al Amin. Hiru, are you there? Dr. Hiru.
Good evening.
Good evening,
sir.
Hiru. All well in Dhaka?
Am I audible?
Yeah.
Yes, sir.
Okay, go ahead, Hiru. Dr. Abhijit, go ahead.
Dr. Hiru, see,
Yes,
I
sir.
want to measure the left atrium.
Yes, sir.
In which part of the cardiac cycle do you measure the left atrium? Is it systole or diastole?
Sir, we will measure it systole, sir.
And how do you know that it is systole?
Sir, as both AML and PML will close.
Okay. And how do you know that the left atrium is enlarged or not?
Sir, as during the when mitral valve is open, then LS size is reduced.
No.
Sorry, sir.
You have to measure the left atrium and tell me that it is normal or big or small. How do you measure
Okay,
it?
sir. Sir, normally it's measured in body surface area. If this is more than 34 ml per meter square body surface area, it will enlarge. But if it is less than 34 ml per meter square body surface area, it is normal.
And tell me, how do you know whether it is 34 ml per square meter of body surface area?
Sir, we will measure it. Sir, we will measure it in biplane method in a 4-chamber view and also in a 2-chamber view.
Yes.
First, we will make from the annulus of the mitral valve, trace it for the endocardium from one annulus of mitral valve to another annulus.
How do you join?
4-chamber view in systole, then in two.
How do you join the two annuli?
We will join
or a curved line?
A straight line from two annulus, a straight line.
Okay. And after drawing a straight line, what is the next step that you do?
Next step, we will measure the smallest length.
From which point to which point?
From shortest, that is shortest, smallest length of the LA we will calculate.
So you'll have to start from the midpoint of the line.
Yeah, sir. Yeah, we will midpoint of the mitral valve to downwards.
To exactly on opposite point, right?
Yeah,
you have to do it in 2 chambers. So what are the two techniques? One is area length method.
Yeah.
The other is modified Simpson.
Modified Simpson method, biplane. That is biplane method.
Okay. Thank you.
Thank you, sir.
Can we go to the next person, please?
Yes, certainly we can go. Dr. Sirisha.
Sir.
Dr. Sirisha, can you hear me?
Yes, sir. Yes, sir.
Now, have you been doing echocardiography?
Just some screening, sir.
Okay, fine. Tell me how to measure the ejection fraction using 2-dimensional echocardiography. Gupta sir, can you show the picture of 4-chamber view? Now, look at this picture and describe what you're going to do. How many views will you require?
Two views, sir.
What are the 2 views?
Apical 4-chamber and 2-chamber, sir.
You are right. And now describe your procedure.
Sir, we will first take a apical 4-chamber view, then we will do modified Simpson's method, sir. We will start tracing from the septum downwards and till the mitral valve will trace, sir. And we'll see that the Purkinje fibers are also involved in the cavity itself, not as a part of.
No. Sorry. See, there's a small technical mistake. You don't see the Purkinje fibers here. You
Yes,
mean to see that you will include the trabeculations on the side of the plug.
Yes, sir. So what I
that
mean is
you mean?
yes, sir.
Trabeculation. And what else, doctor, other than trabeculation? The papillary muscle. That should also
Papillary.
be towards the cavity, right?
Oh, sorry. Yes, sir. Papillary muscles. Yes, sir.
So you start at one annulus and end at the other annulus.
Other annulus.
And then join by?
The midpoint will be there. That will
you join by a straight line.
Straight line at the base.
Yeah. And take the midpoint of the straight line and what
We'll
do you do
drag
next?
it and see that whole of the area is covered properly.
And from the midpoint of the straight line, what do you do next? Join it to the apex.
Yes, sir.
Okay?
Yes, sir.
You do it in 4 chamber, you do it in 2 chamber.
In the 2 chamber.
You do it in diastole, you do it in systole.
Systole. And our machine will automatically give the EF, sir.
Yeah, doctors are bad mathematicians. The machine will do all the rest for you.
Yes, sir.
Okay, thank you, doctor.
Dr.
Sir, can I
Sirisha,
have the
what is your normal ejection fraction, Sirisha?
More than 55, sir.
Oh. Females more than 54, males more than 52.
Okay, sir.
Females have become more masculine than males.
Okay.
Remember that.
Yes.
Okay. Don't say 55, say more than 54 and 52.
54 and 52. Okay, sir.
Right. Dr.
Thank
Ganesh Tukaram Thomare.
Hello?
Dr. Ganesh. Dr. Thomare, Dr. Ganesh Tukaram Thomare.
Where is Dr. Ganesh?
Maybe he'll come back over a period of time. Anyway, Dr. Sayali Nand Kumar Bhangre.
Dr. Bhangre, can you hear me?
Dr. Sayali Nand Kumar. Is Dr. Sayali over here? All right. Then Dr. Sumant Kumar.
Sir.
Sumant
Yes,
Kumar.
Kumar. Can
Yes,
you hear
sir.
me?
Yes, sir.
Okay,
Sir,
Sumant.
can you show me the 4 chamber view, please?
Okay, I'll show you.
Dr. Sumant Kumar,
Yes, sir.
I am interested in knowing whether the right ventricle of this person is normal or large. How do I do that?
Sir, is normal
Or enlarged, dilated.
it's enlarged, sir.
How will you prove that? You say this is dilated, but how will you prove that? What will you do next?
We keep M mode, sir.
No, this is 2D. I won't allow you to use the M mode. M mode is not good, you see.
Okay, sir.
You know,
We
you
keep,
don't know.
yes, sir. I don't know clearly, sir, but we keep measurements, sir. Measure the left ventricular measurement, sir. Diastole and systole measurement.
It is not left ventricular measurement that I am asking. I am asking you right ventricular measurement. From
Yes,
where to where do you measure the right ventricle?
From septum to right ventricular wall, sir.
At what level?
At midpoint, sir.
Is that what we taught you? Doctor, have you been reading or you have got mixed up with all the information that we gave you?
I don't know exactly, sir.
We told you to measure at the base, then at the mid cavity, then there's a longitudinal diameter. Are you aware of this?
Yes, sir. Yes, sir. Yes, sir. Mid cavity, sir.
So if you want to take these measurements, will the heart be diastole or systole?
Systole, sir.
You will have to do a lot of study. You're
sir.
not up to the mark. Sir,
Yes,
can
sir.
I have the next person?
Yeah, Sumant, you have
Yes,
to
sir.
read a little bit better because
Yes, sir.
important thing is all measurements for LV and especially RV, they should be end
Diastole.
end diastole, so
Yes,
that
sir.
they are biggest in size and they are just beginning of systole.
Yes, sir. Yes, sir.
If you will measure during end systole, what will happen? That will be smaller in size automatically.
Small. Yes, sir.
Okay, so just
Yes,
think
sir.
over it before you say something. Dr.
Yes,
Ishwar
sir.
Agarwal.
Actually, I am traveling, sir. Just I can't hear you properly, sir. Actually.
Doctor, when you measure the atria, it must be in systole. When you
Yes, sir.
measure the ventricle, you have to take the diastolic pressure. Will
Yes,
you
sir.
remember
Okay,
that?
sir. Yes, sir. Okay, sir.
Okay. Next
Thank
person, please, ma'am.
Dr. Ishwar Agarwal.
Yes, sir.
Dr. Agarwal, can you hear me?
Yes, sir.
See, I want to measure the systolic function of the right ventricle. Tell me one method. What method you want to describe?
So, kindly pardon the question, please.
I want to measure the systolic function of the right ventricle in this patient. Tell me one method by which you can measure the systolic function.
So, modified Simpson method, and it should be more than 35% to be normal.
Modified Simpson method for right ventricle?
It should be, yes, sir, it should be more than 35% to be normal.
That is not what modified Simpson method. Can you correct yourself, please?
Think
What
over
is-
it again, because what we said is we asked you something different. He's
Okay.
asking for RV systolic function, not for LV systolic function. RV systolic function, how do you assess RV systolic function?
See, you said correctly that it is more than 35%. Are you talking about fractional area change?
So, this is what I remember about RVEF systolic.
What? That is not EF, that is fractional area change. How will you measure the fractional area change?
I don't know, sir.
I think you will have to do a little more of reading.
Maybe,
The
sir.
answer, Ishwar, is fractional area changes at the beginning of systole will trace the endocardium of a RV. This will give us area.
Yes,
Then
sir.
at the end of systole, we'll again trace it. It
So
should
that
be
is
more than
EF. That is same EF.
not EF. EF will have volumes. Here we are talking of area. And RV is a structure which is crescent shape. It has got an inlet, outlet.
Yes, it is very
Apart
difficult
from-
to monitor. Yes, sir.
So in 3 dimensions echo, we do RV measurement like that. But in this 4-chamber view, we'll trace the areas. This is not clearly seen over here. Suppose this is RV, we'll trace the area of RV on this side like this. This
Yes,
is
sir.
beginning of systole and then end of systole. So whatever the change of area is there, which is known as fractional area change, it should be more than 35%. It means almost 35% of blood has been ejected by, or the
Yes.
area has changed by 35%. Remember this particular phenomena. And this is very, very useful, right?
Okay, sir. Yes.
Next person, Dr. Anupa George. Dr.
Yes.
Anupa, yeah.
Dr.
Yes, sir.
Anupa, can you hear me?
Yes, sir. Yes, sir.
Have you been doing echocardiography in the recent past?
Yes, just screening.
You're doing screening. Very good. Now, tell me how to do TAPC. What does TAPC mean? TAPSE. What do these letters stand for?
Sir, it is tricuspid annular plane systolic excursion value.
Very good. And how do you do that?
We can do it in M mode at
You put the line.
tricuspid median.
No, tricuspid lateral annulus, right? And then what do you do?
Tricuspid line. Then take the M mode.
Yeah, it moves up and down, right? And what
The uppermost slope is measured
the uppermost slope?
at the tricuspid annulus.
The uppermost point and the lowermost point, the vertical distance. And what is the cutoff value?
More than 17 millimeter.
More than
17 millimeter.
17 millimeter.
17. Right.
Yes, sir.
If it is less than 17, it shows a poor prognosis. You are right.
Poor systolic function.
Very good. Sir, can I have the next question, please?
All right. Dr. Amit Kumar Potulwar. Amit. Hello, Amit.
Amit, can
Hello?
you hear me? Oh, yes, yes, sir. Good evening, sir. Good evening, Amit. Now tell me.
Good evening, sir. Hello.
Good evening. I want to use the tissue Doppler to measure right ventricular systolic function. And tell me how I'm going to do that. Gupta sir, can you show the fourth chamber view again, please? Now look at this picture. I want to use tissue Doppler and measure the right ventricular systolic function. How am I going to do that?
Sir, initially there is a pulse.
What do you do? Now tell me the step.
In spectral Doppler, there is a pulse wave, first of all, pulse wave.
Where do you put the line?
Place this at leaflet tips of
tips of mitral leaflet?
Mitral
Or
and
tricuspid?
mitral annulus level.
So why mitral annulus, man? I'm trying to measure
Sorry,
the
pulmonary.
right ventricle.
Right one.
Then pulmonary.
Sir.
No.
Answer.
You don't know. Please think and answer. Am I scaring you? You're getting
Hello?
afraid? Hello? Hello?
Sir, clearly not audible, sir.
I
Amit,
want to.
his question is, how do you measure RV free wall systolic thickening by tissue Doppler?
Not nonsense.
All right.
You know what?
Any other question, Abhijit? You can ask him.
Amit, you tell me how you are going to measure the area of the right atrium using planimetry, and what is the cutoff value? Right atrium.
Right atrium area is measured by at the level of diastole.
Diastole or systole? Atrium, systole. Ventricle, diastole.
At the level of systole, then
systole. When the atrium is largest. And from where to where do you measure? And how do you measure?
In right atrium.
Right atrium. I want to measure the right atrium. Now think before you answer.
At the level right.
From where do you start? Have you been doing echocardiography?
No, sir. We will start.
You haven't.
First practice.
Sir, this gentleman has not done echo.
No problems. Just we'll leave it. We'll move to further. No issue, Amit. It's fine. It's okay. Don't loosen your heart. We'll be doing all these things again and again.
We will teach you when we meet you in Delhi.
Yeah, maybe like whenever we hands on, we'll go there and do it. Don't worry about it. Next is Dr. Umesh Rajur.
Dr. Umesh, can you hear me?
Umesh, are you there?
It seems he's not there.
Dr. Safayala Vishal Sardesai. Safila Vishal Sardesai.
Dr. Sardesai, can you hear me? He doesn't seem to be there.
Hello.
Yeah, she's there. She's there. Yeah, go ahead, Dr. Safila.
Yes.
Dr. Sardesai, can you hear me?
Yes. Sir, can you hear me? Yes, sir. Yes,
yeah,
sir.
I can hear you. Now, I want to measure the dimensions of the right atrium using planimetry. Describe the procedure and describe the cutoff value.
So it would be done in the apical 4-axis view, the mid-axis, the midpoint, fourth chamber view. The mid-atrial level is considered, the width at the mid-atrial level.
Systole or diastole?
End systole, sir. End systole.
I am not taking a
horizontal.
I want to measure the area of the right atrium. And how do I measure the area of the right atrium?
So you have to, we have to trace the right atrium along the interventricular septum, interatrial septum, the base, and the end point should be at the tricuspid valve, the tip, the base of the tricuspid valve. There should be a horizontal line, two annular line.
And what is
then the horizontal?
What is the cutoff value?
Tricuspid short axis planimetry should be
No,
less
no.
than 18 centimeters
Oh,
square.
you're right. You have done very well. Sir, can I take the next person, please?
Sure. Good job done, Safla.
Thank you, sir.
Dr. Mitul Jain.
Dr.
Mitul,
Jain, can you hear me?
Mitul, are you there? Dr. Namdev Limbaji.
Yes, sir.
Dr. Namdev, can you hear me?
Yes, sir. Yes.
Dr. Gupta, sir, can you show a parasternal long axis view, please? So, doctor, what view is this?
So this is a parasternal long axis view.
So,
Now
what are the structures that you can see from above downwards?
from above there is a right ventricle. Then there is aorta and left ventricle.
This is left.
Then left atrium.
Left atrium.
Yes, sir.
And what valve is there between the left atrium and left ventricle?
Yes, sir, mitral valve.
And what is behind the left atrium?
This is the descending aorta.
See, there is another small dot that is sometimes visible towards left of this. In that region. What is that hole? The aorta is one hole. Another hole is often visible here. What is that?
This atrial appendage.
No. See, there's a vessel, blood vessel. You can see it as a hole. What blood vessel is available there? Some sort of vein of the heart.
It's a
What
coronary
vein is that?
Coronary
Coronary
sinus.
sinus. Now, what are the two leaflets of the aortic valve that you can see from this view?
So this is the anterior leaflet, and that is the
what
yes, sir,
leaflet?
that non-coronary and coronary.
See, there are two coronary leaflets and one non-coronary leaflet. You have identified the non-coronary leaflet correctly. What coronary leaflet did you see above this? What leaflet was that? In contact with the
posterior.
No,
posterior,
right or left? No. There's no posterior. There's a right coronary artery and a left coronary artery. What leaflet is that?
Sir, right coronary.
Right coronary.
Right coronary cusp, man.
Yes.
Yeah. And can you see the interventricular septum to the left?
Yes, sir. Yes.
What blood vessel supplies the interventricular septum?
For the medial basal is supplied by RCA.
No, man. It is always LAD and the septal perforator of the LAD because it perforates the substance of the interventricular septum. So, what vessel? Can you repeat that, please?
Sir, LAD.
LAD. And what branch of LAD? It perforates the septum. So it is?
That is D1 and D2.
No, it is S1 and S2. Septal perforator 1 and 2.
Yes.
Will you remember that, please?
Yes, sir. Septal perforator 1 and 2.
Abhijit, some people call them as D1, some people call them as S1. Little variation.
So the D1 is quite different. It supplies the lateral wall of the left ventricle. S1 and S2 go into the substance of the septum, but they are not visible in the naked eye examination.
Namdev, this is anterior septum. This is not septum. This is anterior septum. What you said was good for septum, but as soon as the aorta opens up, this becomes anterior septum. Anterior septum is supplied by LAD and that is supplied by RC.
Yes. Okay. Sir.
Okay.
Okay. Sir.
We go to the next person, Dr. Simon Chatterjee.
Dr. Suman, can you hear me? Hello. Dr. Suman, can you hear me? Sir, I don't think he's here.
Dr. Anchala Singh.
Yes, sir. Good evening, sir.
Good evening, Anchala.
Dr. Anchara, I want to take measurements of the aortic root. So just enumerate the structures that you want to measure. 1, 2, 3, 4, 5. Tell me 5 structures in the aortic root that you want to measure.
So, when we talk about aortic root, we will measure it in mid-systole, and when the aortic valve leaflet.
You will measure all the structures of the
Yes,
aortic
sir.
root in systole?
Sinus of Valsalva, sinotubular,
Sinotubular
LVOT and
junction?
aortic root. Yes, sir. And LVOT and aortic root.
Okay. Now, doctor, remember that if you see the annulus, all the structures that are to the left of the annulus are measured in systole. All the structures that are to the right of the annulus are measured in diastole. Would you
And
remember
diastole.
that, please?
Yes, sir.
See, this is what I mean. The annulus is measured in systole. The LVOT is measured in systole.
Mid-systole, sir.
The other structures, that is the sinus of Valsalva, the sinotubular junction, and the proximal ascending aorta, these are measured in diastole. Will you remember
diastole,
that?
sir.
Will you remember
Yes, sir.
that, please? Can you
Yes,
repeat
sir.
what I told you?
So LVOT, aortic root, these are measured in systole, and sinus of
Not aortic root, it's the aortic annulus.
annular, sorry, sir. And
measured
sinus of Valsalva.
It is measured in
systole. Systole.
How do you know that it is systole?
So aortic valve leaflet will be fully open.
Fully open, and it will be parallel to the aortic wall. And the structures that are to the right will be measured in
diastole.
Diastole. What are the
Diastole.
3 structures that we measured in diastole?
Sinus of Valsalva, sinotubular junction,
And
and
proximal ascending aorta.
proximal ascending aorta.
Why is it important to measure the proximal ascending aorta? Your patient has got aortic stenosis. And why do you want to measure the proximal aortic ascending aorta? You know, in some of these patients have aortic stenosis, the aorta may be dilated, and the surgeon may need to replace the aortic root with a prosthetic graft.
Yes, sir. Yes, sir.
Would you
If
remember
it is
that?
not, yes, sir. If it is not dilated, they will not replace it.
You're right.
Yes.
So, sir, can I have the next person, please?
Good, Anchala.
Thank you, sir.
Rahul Gore.
Yes, sir.
Rahul?
Yes, sir.
So, look at this picture.
Yes.
When you measure the sinus of Valsalva and the sinotubular junction and the proximal ascending aorta, in which part of the cardiac cycle will you be measuring them? I told the previous student. Have you been hearing what I'm saying?
Yes, sir.
You measure in systole, you measure in systole or diastole?
Sir, sinotubular junction, proximal aorta should be measured in diastole. Then LVOT and aortic annulus should be measured in systole.
Yeah. And when you measure LVOT and aortic annulus, will you measure leading edge to leading edge or trailing edge to leading edge?
Sir, leading is to trailing edge, sir. When fully open, it's.
No, it is trailing edge to leading edge.
Okay, sir.
And the situation changes when you go to the right of the annulus. All have to be measured from leading edge to leading edge. Would you remember that, please?
Yes, sir. It should be measured when it's fully open in systole, and it is should be leading edge to trailing edge.
You are confused. See, if you look at the left of the picture, that is the annulus and the LVOT, those are measured from trailing edge to leading edge in systole. If you look to the right of the picture, the 3 structures, the sinuses of Valsalva, sinotubular junction, and the proximal aortic diameter, these are measured in diastole from leading edge to leading edge.
Okay.
Sir, can I have the next person, please?
Shashank Prabhu Desai.
Yes, sir.
Shashank, can you hear me? Can you
Yeah, he
hear
can
me?
hear you.
Shashank?
He can hear you. Go ahead.
Sir, can I have another picture, please? Any other picture? Any other picture, please? Shashank, wait a bit. We will show you another picture. So, Shashank, what view
Yes,
is
sir.
this? What view
So
is
this
this?
is apical three-chamber view.
And what are the structures that you can see here?
So you can see the anterior segment, all the anterior segments and inferior segment with the LV. Then I can
You can
see
see the
the
LV. You can see the LV. You can also see the other chambers. What chamber can you?
pardon, sir?
You
Left
can see
ventricle.
the left ventricle. What other chamber of the heart is visible from this view?
So the LV, the OT.
LVOT? Yes. LVOT is a part of the LV. So other than LV, what other chamber of the heart can you hear? Can you see?
The RV, sir.
RV. What else? Can you see any valve?
Aortic valve and mitral valve.
What valve is this?
Mitral.
And what is the other
Mitral
valve?
valve.
Aortic valve and mitral valve. So you can see the interventricular septum.
Yes, sir.
What segments of the interventricular septum can you see in this view?
The basal anterior, then mid anterior, and apical.
Is it anterior or anterior septum?
Pardon, sir?
It is anterior septum.
Anterior septum or anterior?
And anteroseptal, sorry, sir. Yeah.
Anterior septum. This is very similar to the parasternal long axis. Only the picture has been rotated upwards. And what are the other segments of the LV that you can see? The other one.
The inferior segment, sir.
Inferior. So inferior basal, inferior mid. Okay.
Yes, sir. Basal, mid, and apical.
Okay. Sir, can I have the next person, please?
Yeah, sure. Just hold on, I'll get you some questions. I'll just get you some questions.
I can see the picture of a handsome young man. What is his name? Hello.
Go ahead, Abhijit.
Sir, I think you can take the next part of the
Okay,
examination.
I'll do it.
Then I'll chip in.
Sure. Jaising, what are the two important features of cardiac ultrasound wave?
Yes, sir. Good evening.
Good evening, Jaising.
Sound waves. Sir, I didn't get the question, sir. Two important feature of cardiac ultrasound waves.
What is the difference between high and low frequency transducers?
Sir, low frequency transducer for the more deeper structure.
So you are right, but tell me something. So you have got an adult person. You want to use a high frequency transducer?
Low frequency, sir. Low frequency.
Why do you want to use a low frequency transducer?
Because we want to go more deeply.
Better penetration.
Better penetration, sir.
What else?
And better penetration.
Better Doppler studies.
Yes, sir.
And what is the side effect of a low frequency transducer?
Yes.
Poor near resolution.
Resolution poor hoga. Yes, sir.
Near resolution is
Near.
poor.
Yes, sir.
Okay.
Yes, sir.
And what is the positive point of a high frequency transducer?
Positive point for resolution will be better, sir. Penetration
Where?
will be less.
Resolution would be better at what place?
It
Near
near
or
point.
far?
Near
Near or
point, sir.
far? Okay.
Near point, sir.
Okay. Fine, Jaising.
Yes, sir.
Dr. Gote, Shrikant Rajvilas Gote.
Good evening, sir.
Good evening, Gote. Go ahead. Basic routine imaging scan placed in your echocardiographic study.
Planes mean what, sir?
What all views you will take in routine echocardiography?
Four chamber,
What-
two chamber, like that, sir.
What all windows you will use in echo screening or echo doing echoes?
At Apex, sir, apical four chamber view. Apical three chamber view, sir. Left parasternal short axis view. Left parasternal.
We'll start one by one. From plaques, which view you will do from plaques?
Parasternal long axis view and short axis view.
And
also right focusing right.
RV, no, RV, RA inflow view.
Yes, sir, RV, RA inflow.
Then apical window?
Apical four chamber view, sir. Apical three chamber view. And also for two chamber view.
Apical 4-chamber view, 2-chamber view, 3-chamber view. Anything
Yes,
else?
And apical 5-chamber view, also, including
5-chamber view and RV, RA focus view.
Okay.
Subcostal window?
Subcostal view, 4 chamber, sir. Subcostal 4 chamber view.
Subcostal 4-chamber view and IVC view.
Yes, sir.
Not good. Just keep on remembering it, okay? Vinay Sharma. Dr. Vinay Sharma, are you there? Vinay Sharma. Dr. Anudeep Reddy. Anudeep Reddy.
Yes, sir. Hello, yes, sir.
Ideal position for patient of an apical and subcostal window.
Hello, sir.
What is the ideal position of the patient in apical and subcostal views?
Apical view, you should place the transducer at left atrial border.
Listen the question, not the transducer. What is the ideal position of patient?
The patient should be supine or sitting or right lateral, left lateral.
Towards left lateral.
And subcostal window?
Subcostal window.
Subcostal window, what is the position of a patient, man?
The patient should be supine or lateral,
Supine,
left
sir,
lateral or right?
Supine.
Supine.
Okay. So why are you taking so much time, man? This is just a simple, very simple question. Dr. Karanveer, are you there, Dr. Karanveer? Dr. Karanveer Thod.
Hello, good evening, sir.
Good evening, Karanveer.
Yes, sir.
Index marker of for parasternal long axis view.
The index marker should be at 11 o'clock position, sir.
Okay.
In parasternal long axis view.
And in parasternal short
Yes,
axis view?
After completion of parasternal long axis view, we move 2 o'clock view, sir, where we get parasternal short axis view at aortic level, mitral and papillary muscle and apical level.
Subcostal window?
Subcostal window, what exactly I should answer, sir? Means
index marker.
Fourth chamber view, subcostal fourth chamber.
Sir, index marker should be at the 3 o'clock position. Right. And yes, sir.
Good. Next is
Yes,
Dr. Samrat Madanik.
Yes, sir. Good evening, sir.
Good evening, Samrat. What are the normal dimensions of left atrium and left ventricle?
Sir, left atrial area, left atrial area should be it is measured in two views, sir, by the area and length method. And measuring the left atrial area.
My question is different. My question is normal dimension of left atrium and left ventricle in Plaque's window.
In Plaque's window. Sir, LV dimensions in Plaque's window, usually they are diastolic dimensions, I guess, above 49, sir, mm. Systolic dimensions above less than 33. And LA dimensions, sir, I am not able to recollect, sir, properly.
Okay. LV dimension is diastolic dimensions up to 57, 58 absolute value.
Yes,
and it
sir.
should reduce by 1/3. And if you take it in absolute index value, 32 is absolute index value for LV.
Yes, sir.
And 22 is for LA.
Yes, sir. I'll remember that. Yes, sir.
Because we don't talk of absolute value now, we talk of more of a index value, Samrat.
Yes, yes, sir. Yes, sir.
Dr. Tamogna Das.
Yes, sir.
Dr. Das, LV thickens or thins out in systole?
Sir, it thickens in systole.
And sure, are you it thickens?
Sir, the volume decreases, but the wall and the septum thickens.
Then what is the pressure and volume overload?
Sir, pressure overload is when the ventricle is pumping against a closed valve. And volume overload is when there is increased amount of blood.
Volume overload is the increased amount of blood like ASD.
Yes, sir.
Pressure overload is when RV is subjected to pulmonic stenosis.
Sir.
That is pressure overload.
Yes, sir.
Durgesh Makwana.
Yes, sir.
What constitute ECG systole and diastole?
So systole starts from the starting of the Q waves till the end of the T wave. And diastole starts from T wave till the Q wave.
Okay.
Or the peak of the R wave, whichever you want to consider.
Okay, fine. Next person is Kevin Bora.
Yes, sir.
In which cardiac cycle the various cardiac valves opens and close? Mitral.
In which cardiac cycle valves open and close? So the mitral valve opens in diastole and closes in systole.
Aortic.
Aortic, it closes. Aortic valve opens during systole and closes during diastole.
Pulmonic.
Pulmonic opens in systole.
Tricuspid.
Tricuspid during systole.
Tricuspid during systole. Don't get confused. That's tricuspid and mitral valve. They are always diastole.
Diastole.
Okay. Next, Dr. Ravi Bhushan. What does Doppler records? Dr. Ravi?
Hello.
Yeah,
So,
Dr.
good evening,
Ravi.
sir.
Good evening, Ravi.
Good evening. Yes, sir. Good evening.
What does Doppler records?
So, Doppler records the velocities. So, it records the gradients basically.
No, it records velocity. You are right to begin with.
So, I'm sorry. It records the velocity and which calculates the gradients.
Okay. And what kind of a Doppler it records? Pulse wave, continuous wave, spectral Doppler, or colored flow mapping? What kind of a Doppler?
So it does both, all of them basically. So we can have a pulse wave Doppler also. We can have a continuous wave Doppler also. Okay. So for lower velocities, we use a pulse wave Doppler, and for larger or bigger velocities, we use a continuous wave Doppler.
Right. Okay. Thank you. Next person, Chandra Kumar.
Yes, sir. Good evening, sir.
Mahapatra. What is negative and what is positive Doppler shift?
Sir, the flow towards the probe is, sir, always positive shift, and against the probe direction is the negative. If, sir, there will be mitral regurgitation, and there will be the wave will be negative shift, and if there will be aortic regurgitation, there will be positive shift.
What is a tricuspid flow, positive or negative?
In tricuspid, sir, if normal flow is positive, and if TR there will be negative.
Okay, right. Thank you. Ravi Bhushan, Mahapatra is done. Dr. Yogesh Namdev Patil. 3 important modalities of Doppler. Yogesh? Yogesh, are you there? All right. Majrul Islam. Dr. Majrul Islam.
Yes, sir.
3 important
Yes,
Doppler
sir.
modalities.
Yes, sir. Pulse wave Doppler, continuous wave Doppler,
and
tissue wave Doppler.
Okay. So where do you use pulse wave Doppler?
Sir, pulse wave Doppler in the mitral valve, sir.
Where, when you use pulse wave Doppler? In normal subject, deceased subject?
Sir, in mitral regurgitation, sir, we see the pulse wave Doppler.
My question is, pulse wave Doppler is used in normal subject, it's okay. But in deceased subject, what you will use?
Sir, continuous wave Doppler.
Continuous wave Doppler. Okay.
Yes, sir.
Right. Majrur is fine. Dr. Nida Fareen. Nida, are you there?
Yes, sir.
In Doppler study, one should be parallel or perpendicular?
Sir, parallel to the blood flow.
Right? Parallel to the blood flow?
Yes.
Why not perpendicular?
So we will get the maximum gradient by a parallel thing, not by the perpendicular.
Any scientific answer?
Sir, can you repeat it, sir?
Any scientific answer? You said this right. If we have parallel to the blood flow, we get the maximum velocity.
Yes, sir.
Can you explain it mathematically? Cosine of the angle.
Sir, I don't know.
Cosine of 90 is 0.
Yes, sir.
So if you are perpendicular, the dimension of the Doppler will be 0.
Okay.
And cosine of 0 is 1.
And what is the maximum angle you can use?
Sir, what is the maximum?
Cosine angle you can use for calculating Doppler flow velocity. Why it happens? Because sometimes it becomes very difficult to be parallel to the blood flow. So what cosine angle should be maximally used at what like cutoff mark of a cosine angle?
0 to 30 degree.
20 degree.
20 degree.
Okay, last question before we go away, Fardeen, from you is, like Dopplers are parallel, what should be perpendicular?
So for M mode, we should be perpendicular.
Anything else?
What about 2D? Perpendicular or parallel?
Sir, perpendicular.
Correct.
Yes, sir.
So wherever you are imaging 2 dimensions echo, it should be, images will be good if we are perpendicular. If we are doing Doppler, we should be as parallel as possible to the cosine angle of 0.
Yes,
and
sir.
cosine angle should be 90 for 2 dimensions.
2D.
All right. I hope you'll remember this. This is basically fundamental of a color Doppler and 2D imagings. Okay.
Yes. Yes.
Dr. Sai Prasad. Dr.
Good
Sai,
evening,
are
sir.
you? Good evening. Question Sai for you.
Yes, sir.
When do you employ pulse and continuous wave Doppler?
So pulse wave Doppler is used in normal valves and vessels, and continuous wave Doppler is used in regurgitant and stenotic or shunt pathology.
Why do you use continuous wave Doppler in stenotic shunt pathologies?
Yes, sir, we use.
Why?
Because we need a continuous flow to assess the shunt, sir.
Flow
And
will
also
be
the,
flow will be continuous even if it's shunt, even if it's a mitral valve.
What type of calculations will you require in stenotic orifices that you want to use pulse wave Doppler? See, I'll give you a hint. What comes in is equal to what goes out. Hear me again. What comes in will be equal to what goes out. This is an equation. What equation is this? Heard of continuity equation?
Pardon me, sir?
Continuity equation. Continuity equation. What comes in is equal to what goes out.
Okay.
For that, you will require the pulse wave Doppler.
Okay. I remember that, sir. Thank you.
Thank you.
Okay. Thank you, Sai.
Thank you,
Dr.
sir.
Manu Kapil. Manu, are you there? Dr. Kapil Manu. Dr. Clay from Tanzania. Dr. Clay.
Yes, sir.
Okay,
Hello?
Doctor. No. How are the mean gradient and velocity time interval obtained from a Doppler tracing?
So in Doppler tracing, the mean velocity can be obtained when by using Bernoulli's equation, sir.
See, you have got a tracing, a Doppler tracing. Okay. And using the Doppler tracing, I am asking you to find the mean gradient. How do you get the mean gradient from a Doppler tracing? That is Dr. Rakesh Gupta's question. You have got a Doppler tracing of the aortic valve. And how do you get the mean gradient of the aortic valve? What do you do with a Doppler tracing to get the mean gradient? You have to do something.
I think probably you might use the maybe the stroke volume against the mitral valve.
No, trace the Doppler envelope, man. It's a very simple thing. Once you trace the Doppler envelope, suppose this is the Doppler envelope, like you just trace the Doppler envelope, it will give you peak velocity, peak gradient, mean velocity, mean gradient, and velocity time integral automatically.
Okay, sir.
Got it or not? Once you trace the Doppler, it automatically gives you everything. So you have to trace the Doppler spectrum pattern. Dr. Clay, is that fine?
Yeah, yes, I can hear you.
Okay. Before we go away, can you tell me that peak pulse wave Doppler or continuous wave Doppler, which of these is site specific?
So come again, sir?
Between peak pulse wave Doppler and continuous wave Doppler, which one is site specific Doppler?
Site because when we use a continuous wave, sir.
Dr. Clay, I will modify sir question. See, suppose I am doing an apical 5-chamber tube, and I want to measure the velocity at the level of the LVOT. So what Doppler do I use? Do I use PW or CW?
Sorry,
I want to measure LVOT velocity, left ventricular outflow tract velocity. Shall I use continuous wave or pulse wave?
I can't hear you nicely, sir. Can you like modify again? You're saying that
I am trying to measure the velocity at the point of the left ventricular outflow tract. See, my machine gives me two types of Doppler: continuous wave Doppler and the pulse Doppler. Which Doppler shall I use to measure the velocity of the left ventricular outflow tract?
because for continuous Doppler,
No,
we use pulse wave Doppler. That's why it is known as site specific. At one particular point, if you're measuring velocity, we should always use pulse Doppler.
But this continuous wave is being used for the high velocity, because like from the previous lecture.
Yeah, we'll explain that again. Suppose what exactly we have LVOT diameter and LVOT VTI by pulse wave, right?
Okay.
That is the amount of blood flowing through LVOT. But we do not have we have now next is aortic valve. At aortic valve, we have an aortic valve VTI by continuous wave Doppler. But we do not have aortic valve area, right? So to get the area, we divide LVOT VTI into LVOT area by aortic valve VTI.
Okay, sir.
That's how it happens.
Yeah.
We'll be telling you all these things again and again, but now we want that you should have a very good idea before you jump to now practical echo. Till now, we are talking about basics of echocardiography, right?
Okay, sir.
Right. Now we go back again. Dr. Balram.
Yes, sir.
Back to you. Two important advantages of color flow mapping.
So you do color flow mapping after 2D. It's a quick way to see, a quick and easy way to see if there's any valvular problem right away, and also to see any ASD, VSD.
Okay.
The advantages, I guess that's it. The ease of use is the main thing.
First is quickly tells you about valves. It quickly tells you about stenotic lesion. It quickly tells you about regurgitations.
Right. ASD, VSD.
It tells you about that also.
Yes, sir.
Okay, fine. It's okay. Anything, Abhijit, would you like to add something in it? All right. Balram is fine.
Thank you.
Next is Dr. Vasudev Utpat. Dr. Vasudev, are you there?
Yes, sir. Good evening.
As per universal convention, what determines the blood flow of a color on color flow mapping?
Flow which is coming towards the probe is colored as a red and going away is colored as a blue.
Good, good. And this is known as BART, blue away, red towards. BART.
Yes.
Tushar, Tushar Kamal Kishore Charkha. Tushar, are you there? Tushar? No. Pyam? Dr. Ghanshyam Motisaria.
Yes, sir. Yes, sir. Can you hear me?
Just a minute. I'm going to come back.
Okay.
What is Bernoulli's equation, Ghanshyam?
Bernoulli equation measure gradient, and it is for multiply by velocity square.
This is modifies Bernoulli's equation. In fact, if you look at a real Bernoulli equation, it's a Hughes Bernoulli equation. So whatever we use is a modified Bernoulli's equation, and this helps you in converting your velocity to gradients.
Gradient, yes.
And we can look at a peak velocity that give you peak gradient. How do you get mean velocity?
Mean velocity, we are tracing 3 cycles in normal sinus rhythm.
Right.
And if atrial fibrillation, then we tracing 5 cycles.
Okay.
And we are getting mean velocity.
Right. Great. Where are you located, Dr. Ghanshyam?
I am from Surat, Gujarat.
Okay. Good. You have a Doppler machine with you?
I have just almost a week.
Just arrived, huh?
Yes, yes.
Okay. All right. Thank you. Good answers. Dr. Swapnil?
Hello, sir.
From which structure the RA pressure is derived?
Dr. Sapil, can you understand the question or shall I explain?
Let him understand. Let him understand, Abhijit.
No. See, listen, I have got a patient and I want to assess his RA pressure. How do I do that?
So, pardon me, sir.
I have got a patient on my echo table and I want to measure his RA pressure. How do I measure the RA pressure? Which structure shall I examine? Which
continuous wave Doppler at the tricuspid valve?
No. I'm not asking about the Doppler. I am asking about which cardiac structure shall I examine to find the RA pressure?
Abhijit, you are back.
Sir, I got disconnected because of the
No, you're back to my original question, that which structure?
Yes, sir. Sir, I was just trying to give you a lead. I've always been doing this in DM exams, trying to pass people who are failing.
No, look, Abhijit, you know what exactly happened? I was taking exam for DM anesthesia, cardiac anesthesia at this Bangalore, Narayana.
Yes, sir.
And there I came across this question.
Yes, this is a very fair and reasonable question.
Tricky question, you know.
So with the help of PR jet, we can find out what is the PA pressure.
RA pressures, how do you drive RA pressure?
RA pressure.
Swapnil, this question is a little tricky. Put your mind together.
Swapnil, you have to measure a structure which is outside the 4 chambers of the heart. It is not RA, RP, LA, LP.
The IVC?
Yes, you got it.
IVC, sir.
So what is the normal IVC dimension and how do you get RA pressures now? Good, Swapnil. That's how it happens, man.
So we see for the collapsibility of the IVC using inspiration and expiration.
Excellent, great.
With
and we
sniff
see
also.
whether it is collapsing more than 50%.
Okay. Good. Reasonably good. We are not.
And if it is not collapsing and dilated, then we would call it as IVC plethora, which
And
means
when
there's
you call
increase.
it dilated, how many millimeters?
So that I didn't read, sir.
21.
Okay,
21. Okay, sir.
And when do you say that it is hypovolemic?
Less than 10, sir.
12. 12
Okay,
millimeter.
12. Okay, sir.
All right. Thank you. Thank you, dear. Rahul Kenkan.
Thank you.
Yes, sir.
Tired, Rahul?
Yes, sir. Yes.
You are tired?
No, sir. I'm traveling.
Okay. You said, yes, sir, I'm tired.
No, I'm traveling. I can hear you.
Okay. Name the echo windows for interrogation of tricuspid regurgitation.
So tricuspid regurgitation, we can view it in the apical four-chamber view or the short axis view with aorta in the center.
Or there are total 5 windows are there, man.
So the apical four-chamber, short axis with aorta in center. Yeah, even IVC can give us
what is the modified apical fourth chamber by which you can see the tricuspid regurgitation? How do you modify the apical fourth chamber? I'm giving you a lead.
Sir, by focusing on the RARV, will shift one intercostal space up and towards the mediastinum.
Well, that is good. Any other view to see the tricuspid regurgitation?
Sir, the RARV inflow view.
Good.
Excellent.
Very good. One more.
RARV.
You move away from the chest. Move away from the chest. Any other view that will help you?
Sir, IVC subcostal view.
Great one. Subcostal four-chamber view.
Yes.
Wonderful. God bless you.
Yes.
Good, Rahul. Good attempt. Very good
Thank
attempt. Dr. Krishna Yadav.
Yes, sir.
What is the main criteria for increased pulmonic artery pressure based on Doppler? Again, a tricky question. Based on Doppler, what is the main criteria of increased pulmonary artery pressure?
Cannot recollect.
Speak loudly.
I cannot recollect.
You cannot recollect. Okay, we'll come back. If you're doing a Doppler study, you want to calculate pulmonary artery pressure, how will you do it? TR jet velocity, man. TR jet velocity. Is that right, Krishna Yadav?
Are you still there, Krishna?
Yes, sir.
What did sir tell you? He gave you the answer. What is the answer? TR jet velocity. From that,
what you'll measure in TR jet? Krishna, listen to this question very carefully. Next person is going to tell you about all this. Mrs. Jigna Viresh.
Yes, sir.
Tell me what is the main criteria for increased pulmonic artery pressures?
Sir, if it is, we measure the tricuspid regurgitant flow. If it is more than 40, for above 40 is mild pH, above 50 is a moderate pH, and above 70 is a severe pH.
The answer is the pulmonic TR jet velocity. Peak TR jet velocity is the main criteria for calculating pulmonary artery pressure along with RA pressures. That should be your answer. And even if it's considered as increased, velocity has to be more than 2.9 meter per second plus RA pressures. Right?
Yes, sir.
So because we don't consider peak velocity as the pulmonary artery pressure, we always consider mean velocity. So in this context, how do you calculate mean velocities? How do you calculate mean pulmonary artery pressure?
By tracing the TR jets,
No.
mean pulmonary
I
artery
did not
pressure,
expect from you. I did not expect from you, Jigna.
the PA and diastolic pressure by putting
No.
mean based on Doppler, what is the main criteria of increased pulmonary artery pressure? So can you repeat the question, sir?
It's there in front of you.
This is the question based on Doppler. What is the main criteria of
Main
increased
criteria is Doppler flow velocity of tricuspid regurg. Add RA pressure to it, you will get a peak pulmonary artery pressure. I want to convert my peak pulmonary artery pressure to mean pulmonary artery pressure. How do I correct them?
There is a formula for a mean pulmonary hypertension. The 0.6 into peak PAP plus 2.1. I just have to recollect that, sir.
Oh, you're doing a lot of echoes and you are trying to recollect.
Mean pulmonary artery pressure. So we generally do the pulmonary artery pressure, sir.
We will give it to Jayanti. Jayanti, you would like to add?
What, sir?
How do you calculate mean pulmonary artery pressure from peak pulmonary artery pressure?
No, sir.
Oh, come on, Jayanti. Both of you are not, I'm not really happy with both of you.
So that is a formula, sir. 0.6 into peak pulmonary artery pressure plus 2.1 is the formula.
2.1.
Yes, sir.
So if you calculate TR jet velocity, suppose TR jet velocity is 3 meters per second, that becomes 36. You add RA pressure to it. Suppose the RA pressures are 5, so it's 40, correct?
Yes.
So peak pulmonary artery pressure is 40. The mean pulmonary artery pressure will be 40 into 0.6 plus 2.1. 24 plus 2.1 would be 26.1. So mildly elevated pulmonary artery pressures. You remember this, both of you?
Yes, sir.
Because otherwise, I don't know how do you do it then, calculation of pulmonary artery pressure. Your ma'am calculates it or not? Your Anuprita madam calculates or not? All right, Dr. Ranjit Shankar Moite. Ranjit, are you there?
Yes, sir. Yes, sir.
Question for you. If the TR jet velocity is 5 meters per second, RA pressure is 10. What is peak and what is mean systolic pulmonary artery pressures? Ranjit?
RVSP is 100.
RVSP is 100, okay.
Then 102.6.
No. 100 in plus 10, that will be peak
Plus 10,
pulmonary
plus
artery
10,
pressure.
yes. Yeah, plus 10.
And then what would the mean?
0.6 into 110.
Correct. And
plus 2.1.
Correct. Good. Now you'll not forget ever in your life.
Yes, sir. Thank you.
Dr. Bhatkar, Dalip Pandit.
Yes, sir. Yes, sir. Good evening.
Important two-dimensional feature of pulmonary hypertension.
Sir, in pulmonary hypertension, we will see dilatation of right ventricle and bulging of the septum towards LV in short axis.
Suppose I've got an ASD. Even the bulging of septum would be there in ASD also.
Pulmonary hypertension, sir. we can, sir, dilatation of right ventricle.
What happens to the pulmonary valve?
Pulmonary wall.
Valve.
Sir, it is stenotic. If
It's not
stenosis
stenosis.
is there, then
No,
hypertension.
no. My patient has got no stenosis. My patient has got pulmonary hypertension, but no pulmonary stenosis.
Sir, then regurgitation will be there. If no.
My question is very simple, dear. Question is important 2D feature of pulmonary hypertension. There'll be RV would be bigger than LV in parasol short axis view.
Yes, sir.
Interventricular septum would be flattened.
Flattened. Yes, sir.
If RV systolic pressure is more than LV systolic pressure, it will be bulging towards LV during systole.
LV. Yes, during systole. And if it is
if it's in ASD where is volume overloaded, there will not be bulge.
Okay, sir.
During systole, right?
Yes, sir. Yes.
That's how we differentiate.
Yes, sir. And if in case of pulmonary embolism, we can also get a McConnell sign also.
Yeah, we can get that also.
Yes.
All right. Now you become intelligent than me now.
No, sir. I am just starting pharma doing my.
No, it's okay.
And
It's
you
okay.
are.
Next is Dr. Dinesh Tiwari. Tiwari ji, are you there?
Yes, sir. Yes, sir.
What information is obtained from a Doppler signal of Prj?
Prj is sir about pulmonary hypertension.
Oh.
And pulmonary. Yes, sir.
Kaise? How do you get a pulmonary hypertension?
So if the jet velocity is high, then we consider it as a case of pulmonary stenosis or pulmonary hypertension. Or
listen to my question very carefully.
Yes, sir.
In pulmonic stenosis or pulmonic flow, there are two patterns are there. One is a systolic forward flow, when the velocity is high, which gives you a PS signals.
Yes, sir.
On the other hand, there is a regurgitation velocity, PR jet velocity.
Yes, sir.
What does this PR jet velocity tells you?
So it's tell about the that may be functional PR due to secondary to pulmonary hypertension.
What is the significance of PR jet signals? Read, Dinesh. You have to read it definitely. Okay.
Okay, sir. Sorry.
I did not like it at all. Dr. Bhimrao Dhruv Singh Pawar. Dr. Pawar, question for you.
Yes, sir.
What is the importance of recording PR jet signals?
No, sir, I don't know this. Answer.
Rakshit Bhardwaj. Rakshit, are you there? Ankan Patel.
Yes, sir. Hello.
What information do you get from Doppler signals of PR jet?
Sir, we know, sir, that pulmonary hypertension is present or not, sir. And sir, pulmonary, sir, any sir regurgitation is there not, sir?
No, Ankan, this is not the real answer.
Sir.
Dr. Nitin Gupta.
Sir, I will try to get it from Ankan. See, Ankan, can you hear me?
Sir.
You are getting pulmonary regurgitation check. So, what information are you getting? It is the pulmonary diastolic pressure or systolic pressure. What pressure are you getting?
Sir, sir, during the diastole, sir, sir, if there is a regurgitation jet, sir, then
you are getting pulmonary diastolic pressure or systolic pressure?
Sir, if there is a regurgitant jet, sir, then diastolic pressure is increased, sir.
So can you measure the end diastolic pressure pulmonary? And how do you do that?
Sir, that I don't know, sir.
Sir, I think we'll have to ask the next question. Next candidate. He doesn't know.
Dr. Nitin?
Nitin does not seem to be there.
All right. Dr. Hiru Al-Amin. Hiru?
Yeah, sir.
You will be able to tell us this question.
Sir, from Prj, first of all, we can calculate the mean pulmonary artery pressure by peak gradient of Prj. Another thing, we can see whether pulmonary hypertension as pulmonary artery dilated, then a PR occurs. So I think those two are.
Anyway, good try. My answer is, if you look at a PRZ, there are two gradients are there. One is the early diastolic gradient. Second is a late diastolic gradient.
Late diastolic, yes, sir.
Early diastolic gradient, suppose is 2 meters of flow velocity. 2 into 2 into 4, that's 16. Plus RA pressure to it add, that'll give you mean pulmonary artery pressures.
Yeah.
And this is very good where we do not get a TRZ velocity signals.
Yeah.
Then late diastolic or end diastolic signals before systole, that late diastolic signals will give you LA pressures. In the LA pressure in the absence of any pulmonic pathology.
Stenosis.
So suppose that is 1 meter per second. So that gradient is 4, add RA pressure to it, that will be 5. 4 plus 5, that is your LA pressure is 9 millimeters of mercury. Reasonably normal. So this kind of formula is very useful when we are working in labs, when we do not have any answers for TRZ velocity and we want to confirm our LA pressures also. So that's how it works here, right?
Yeah, yes, sir.
Okay. Next question, I'll give it to Dr. Sirisha. Sirisha? Dr. Sirisha, are you there?
I don't think he's there.
Dr. Ganesh Tukaram?
Ganesh was not there before.
All right. Sayali Nandkumar Bangare is also not there. Sumant Kumar?
I don't see Sumant Kumar.
Sumant, chance to improve yourself. Okay. Ishwar Agarwal?
Ishwar is not here.
Anupa George?
Yes, sir.
Anupa? Very simple
yes,
question,
sir.
you have got it.
Okay, sir.
Ideal scan plane to study Doppler of mitral flow.
Apical 4-chamber
And
parasternal long axis view.
Parasternal
No, sir. No, sir. The
apical 4-chamber,
sir,
3-chamber,
parasternal
2-chamber.
Yes, apical.
4-chamber, 3-chamber, 2-chamber. Very simple.
Yes, 4-chamber.
That's why I said you got the best question. You know, there's nothing significant in this question. Why we want to say ideal scan plane for Doppler for mitral valve? Why do
Because
we say
it is
that?
parallel. The flow of blood flow to be parallel to the mitral valve.
And then why we were going to parasternal long axis view then?
No, it's by mistake. It's perpendicular.
By mistake. Your probe slipped from apical window to Pilax window.
Yeah.
Okay, good.
That's...
What is the normal flow velocity across mitral valve, Anupa?
Hello, sir.
Normal flow velocity across mitral valve.
It should be normal. It is 0.8 meter per second.
Oh, सारा काम खराब कर दिया आपने. जितना गेन किया सारा लॉस कर दिया Anupa. We have been saying this thing again and again. Remember only 2 velocities. Remember mitral, remember aortic. Mitral is 1.3.
Yes.
Remember mitral is 1.3, aortic is 1.7 maximum. Half of mitral is tricuspid, half of aortic is pulmonic. So mitral flow velocity is 1.3 meter maximum.
Yes.
Right? Chalo,
Yes.
good. God bless you. Take care.
Ups.
Next is Dr. Amit Kumar. Potulwar. Amit. Are you there?
No.
Umesh Rajur.
No.
Safela Sardesai. Dr. Sardesai.
No.
Mitul Jain is absent. Namdev Limbaji Chaure.
Yes, sir.
He must be thinking I'm getting 5 questions in one go. Namdev, very simple. You have to mix and match. Where do you keep the sample volume for?
For mitral velocity at the tip of the mitral valve.
At the tip of the mitral valve. Tricuspid valve.
Also at the tip of the tricuspid valve.
Aortic valve.
Aortic valve just lift to the annulus.
The tip of aortic valve, man. All leaflets, all velocities to be calculated at the tip of the mitral valve. Tips of the valves. Very simple question, you know. It's trying to confuse you. And I'll confuse you more in some time. So, answer is any velocity which you measure should always be just tested to the tip of the leaflets. Mitral, aortic, tricuspid, pulmonic, wherever it is. Where do you keep the sample volume for mitral regurg?
Just beneath the walls.
Below the leaflets.
Yes.
Tricuspid?
Yes, for regurgitations.
Aortic? Mitral
Yes, sir, just
at
beneath
mitral
the,
annulus, tricuspid at tricuspid annulus, aortic at aortic annulus, pulmonic at pulmonic annulus, and LVOT?
At the aortic annulus.
At LVOT. LVOT is just 2 to 3 millimeters away from the aortic annulus.
Yes, sir.
Right? Very simple. There's nothing rocket science in it. We just want to tell you, like, whenever you measure velocity, it should be the tip of the leaflets. Whenever you measure regurgitation, they should be under or below the leaflets or the corresponding valve. Very simple question, nothing specific about it. Okay?
Okay, sir. Okay.
Great. So next question goes to Dr. Simon Chatterjee. Suman?
He's not there.
Suman had come for a few seconds and it disappeared. Dr. Anchala Singh.
Yes, sir.
Oh, you got a very simple question. Normal velocity of mitral valve. Quick, 1, 2, 3, 4.
So 1.
आज खाना नहीं खाया आज.
नहीं sir, 1.5.
No.
For mitral valve.
Remember two things, mitral valve and aortic valve.
Yes, sir.
How much is mitral valve? How much is aortic valve?
अंचल अगर आप क्वेश्चन का जवाब नहीं देगा ना तो उसका एक आंसर है. सारी रात रामायण पढ़ी, सवेरे उठ के पूछा सीता किसका बाप था. अभी तो बताया आपको 3 मिनट्स पहले.
Yes, sir. 1.7.
No, that is aorta. Aortic valve.
Aorta ka half, sir. 0.9 is pulmonary valve. Yes,
And
that is
mitral?
pulmonary.
Mitral?
Mitral 2.
A little less than aortic valve?
Abhijit is feeding you very well.
1.3? And half of that is tricuspid
Anchala is
valve?
1.3 mitral valve. Half of that is pulmonary. Tricuspid.
Pulmonary. Tricuspid.
Tricuspid. Okay.
Tricuspid. Yes, sir.
I hope you remember.
Yes, sir. 1.3.
Anchala, I'm sorry, I'm going to ask you a personal question.
Yes, sir.
Are you married?
Yes, sir.
Do you have kids?
Yes, sir.
Name one kid as aortic valve. Name other kid as mitral valve.
Okay, sir. So I have only one kid.
I'm sorry. Take your husband as a first kid, you know.
No. I am your second kid.
Your husband is a bigger kid, so keep it an aortic velocity at 1.7 and the younger one is 1.3.
Okay, sir.
Then
Thank
you'll
you,
not
sir.
forget ever in your life.
Yes, sir.
Because why it's important, you know, tomorrow if I'm going to talk about mitral stenosis, aortic stenosis, we are going to talk about velocities.
Yes, sir.
So unless until we know the normal velocity, how will we remember whether this valve is stenotic or not?
Yes, sir. Yes, sir.
And may convey my respect in regard to your husband also. I'm just joking. He's one of the loving person we ever. All right. Thank you, Anjala. We move on to Rahul Gore.
Yes, sir. Yes, sir.
What are the normal dimensions of LA? LA.
Sir, LA is less than 34 centimeters, sir.
39 millimeters or 22 millimeters per meter body surface area. Remember, Rahul, write it down on a wall. जब हम MBBS में पढ़ते तो हम क्या करते थे, पूरी दीवार भर देते थे चार्ट लगा के. You remember that time of your MBBS?
Hello.
Yes. Do you hear me?
Hello. Hello, sir.
Rahul, you can hear me?
Hello, sir.
Yes, Rahul.
Yes, sir.
Avicus separation.
Yes, sir.
Abhijit, ask this question. This is from your side.
Yeah. How much is Avicus separation?
Not getting, sir.
Forgot me. How much is key point septal separation? Sir, इन लोगों ने पढ़ा नहीं.
Okay.
I'll give you another.
Hello.
I'll give you another question.
Yeah, please go ahead, Abhijit.
Sir, show the next picture, please.
Hello. Hello.
Show the next picture, please. When do we say that the aorta is dilated?
Hello.
Hello. Can you hear?
Hello.
Sir, he can't hear.
Yeah, Rahul is not able to hear. Let's move to Shashank Prabhu
Hello.
Desai. Shashank. Are you there, Shashank? Shashank Prabhu Desai. Jai Singh.
Yes, sir.
Good.
Hello.
Jai Singh.
Yeah.
Rahul will come back to you
yes.
later on, Rahul.
Hello.
Jai Singh, what is the normal dimensions of LA?
39 mm, sir.
Or Avicus separation?
AB walk-up separation, sir.
15 to 26. 15 to 26. 39, okay. 15 to 26. E point septal separation?
22.
E point septal separation is 7, man. 22 would be like dilated belly dilatation. Use LV. 7 millimeters.
7. Okay, sir.
This is LA. This is Avicus separation.
Right, sir. Right. Okay.
And when
sir,
the mitral valve opens, this is E point septal separation.
Right, sir.
Then D excursion and EF slope. D excursion is again of 15 to 26 and EF slope is up to 50 to 150 millimeters per second. 50 to 150 millimeters per second. Remember, these are going to be utilized now in subsequent classes.
Right, sir.
Right, Jaising? पढ़ो.
Yes, sir.
जरूरी
Yes,
है.
sir.
आपकी फोटो बहुत स्मार्ट फोटो लगाई हुई है आपने. एको में भी उतना ही स्मार्ट चाहिए.
Sure, sir. I will try.
Right.
Okay.
Dr. Shrikant Gote.
Yes, sir.
When aorta is dilated?
Sir, at the annulus, sir.
No. When do you say aorta is dilated? What is the normal aorta's dimensions? (15 to 26 again. And whenever it's more than that, it's dilated. When LV is dilated, it's short axis view. When LA is dilated?
More than 45 mm, sir.
More than 39, 40 millimeters of size. When LV is dilated, when LV size is in short axis is more than 57 millimeters. Or E point septal separation is more than 7 millimeters. Then LV is dilated. Read, man, this is an important issue to read again and again.
Sir, yes, sir.
Next is Dr. Vinay Sharma. He is not there. Vinay is not there. Dr. Anudeep Reddy. Anudeep Reddy.
Yes, sir.
Where
Hello?
do we measure aortic flow velocities, Anudeep?
Hello.
Are you able to listen, Anudeep, to us?
Yeah, yes, sir. Yes, sir.
Where do you measure aortic flow velocity? Anudeep, this time better buy a small laptop.
Okay.
These mobile phones are not very useful, you know, for all this. iPhone especially not.
Okay, sir. Hello?
So where do we measure velocities? Aortic flow velocities.
Hello? Hello? Hello, sir. Can you hear me?
I'm able to hear you. Please go ahead.
Sir. Ascending aorta in suprasternal position, sir, no idea, sir.
This is not right, Anudeep. Neither you're reading nor you have a laptop.
Okay, sir.
Dr. Karanveer, Dr. Karanveer. Dr. Samrat Madanik.
Hello, good evening, sir. Yes, sir. We
Good
can
evening,
measure the
Samrat.
aortic flow. Yeah, we can measure the aortic flow velocities in apical 5-chamber view, sir, by placing continuous wave, pulse wave Doppler, and if there is stenotic case, then placing continuous wave Doppler across the aortic wall. Also, it can be measured in apical 3-chamber view, sir.
And we can measure in 6 different windows, Samrat.
Yes, sir. Right parasternal window also we can measure.
Right
sir.
parasternal 3.
Yes, sir.
Suprasternal.
Yes, sir. Suprasternal. And that.
4.
And in
4,
between
yes.
suprasternal and parasternal, there is another view, right? Infraclavicular.
Then right anterior oblique view will show you in live demonstrations.
Right.
What
Yes, sir.
right
Yes, sir.
anterior
Right
oblique
anterior.
view we showed with, like putting a pillow behind. In suprasternal window, we'll put a pillow behind
Yes,
both the
yes.
shoulders.
Yes,
But
sir.
in
Yes,
right
sir.
anterior
Yes, sir.
oblique view, we put a pillow behind just right shoulder.
Right shoulder. Right. Yes, sir.
And then subcostal window.
Yes, sir.
Right, Samrat?
Yes, sir. Yes, sir.
Okay.
Thank you, sir.
Then Dr. Tamogna Das.
Yes, sir.
Are you there, Tamogna?
Sir.
Where do we measure mitral flow velocity?
So we can measure from the apical 4-chamber view, the apical 2-chamber view, apical 3-chamber view. And also, sir, we can measure from apical 5-chamber view as well.
Okay.
Then, sir, we can measure from subcostal view.
Okay, good. But when do you measure from subcostal window? In which condition, in which patient do you measure from subcostal window?
Sir, in COPD patients.
Perfect. God bless you, Vita.
Thanks.
We were expecting, we expected a very good answer from you.
Sir.
Because heart becomes almost vertical.
Yes, sir.
Great. Dr. Durgesh Makwana.
Yes, sir.
Where do we measure tricuspid flow velocity?
In apical 4-chamber view.
Done.
And tricuspid, no? we can measure also in parasternal short
I'm not going.
axis.
I'm not going to
RVR.
measure. Don't say we. You say I can measure.
So I am sorry. I am going to measure tricuspid, no? Yeah, in subcostal view.
Done.
And in short axis, when we can see RARV, what we say that view.
We'll start from Plaque's window. Do we see in Plaque's window?
No, sir. Plaque's window, we don't see
Okay.
tricuspid valve.
Then in Plaque's window, any modification of Plaque's window we see tricuspid
Yes, sir.
flow?
If we move the tail towards the RV, huh, sir. Pardon, sir.
Move the tail means what?
Move towards the mediastinum. We have to move the probe direction
Tilt,
towards the mediastinum.
Tilt the footprints toward mediastinum. We
Yes,
get
sir. Tilt the
RVRA view.
Yes,
That
sir.
is
Yeah,
first
that
window.
Yes,
Then
sir,
next.
that is first one. Next in apical four chamber.
No,
view,
no,
sir.
no.
Then we
Parasternal
can.
short axis view at aorta.
Yes, sir. Yes, sir. We can have a short axis at aorta.
Yeah, so
Center
two
aorta,
windows.
and we can see RA, RV, and then RVOT track and pulmonary artery.
Correct.
So in that view,
Any modification of the apical fourth chamber view?
any
Modification of apical fourth chamber view?
in modification of apical four chamber view.
Suppose you go up by one space and move close to the sternum.
Yes, sir.
He has
In
given you
that
the answer
view-
already, man.
Yes, he has given me the answer also. So I doubt right parasternal view also can we see?
RVRA focused view.
Yes, sir. RVRA focused view.
So four windows. First you
Yes,
said
sir,
is
four
RVRA inflow view. Second is
Yes, sir.
short axis view at aorta. Third is four chamber view. Fourth is
Yes, sir.
modified four chamber view. And fifth.
Yes. Right parasternal. This can be subcostal, sir. Subcostal. We can see.
Subcostal.
Yes, sir.
Subcostal.
Yes, sir.
Not right parasternal.
Yes,
Not
sir.
right
Sorry.
parasternal.
Yes, sir.
Right
Subcostal.
parasternal is good for. Apart from aortic valve, where else? What else you can see from right parasternal? Anyway, that's not up to your
No,
level.
sir. I
Okay.
don't. I don't know.
I'm
sir.
not going to talk about that. I'm sorry.
No, sir. Yes, sir.
Okay. Next, Kevin Bora.
Not here.
Hello.
Okay. Kevin, are you there? Good.
Yes, sir.
Tell me, Kevin, where do we measure pulmonic flow velocities?
So we can measure in parasternal short axis at the level of aorta.
Good.
And we can measure at long axis, short axis. Then we can measure at apical. Then we can measure in RARV inflow.
RA inflow. Where do we see pulmonic valve, man? We don't see pulmonic valve.
No, we don't see pulmonic valve. I think only that's the view.
No.
Apical.
Subcostal short axis view. As we make IVC view, when we have a subcostal four chamber view, we do a counterclockwise rotation to make IVC.
Yes,
and
sir.
if we tilt at that particular point, let the footprint look slightly towards aorta, we will open up the pulmonic artery.
Yes, sir.
And this is very good seen during COPD patients, Kevin.
Yes, sir.
And this is one pulmonic artery which is very, very difficult majority of time. Plaque's window is always bad, and in subcostal window, then we can see this pulmonic artery. Okay?
Yes, sir.
Right.
Yes, sir.
Ravi Bhushan. Ravi, are you there?
Yes, sir.
Name the windows where we measure aortic flow velocity.
So we can do this in 5-chambered view, 3-chambered view, and 5 and 3. I think so. 5 and 3. That's it, sir.
Ravi, अभी तो रामायण पढ़ रहे थे हम 2 मिनट पहले ही तो.
So we can do this in short axis, sir. Short axis.
Short axis where?
At the aortic level, sir, and in
Aortic
subcostal.
No, Ravi.
So
Will you move to the right of the sternum?
Ravi, I'm amazed.
I'm sorry, sir. I just got a bit distracted.
Right parasternal?
Right parasternal, of course, sir.
Then right infraclavicular?
Right infraclavicular.
Then RAO?
And RAO, yes. I'm so
Then
sorry, sir.
Suprasternal?
Suprasternal also, yes.
Then
yes.
subcostal?
Subcostal also. Absolutely, sir.
We just talked about it.
Yes,
Ravi,
yes,
2
sir.
minutes back.
Very sorry, sir. I got distracted, sir.
All right. Next is Dr. Chandan Mahopatra.
Yes,
Chandan,
sir.
are you there? Chandan, tell me, what do you understand by peak velocity?
Sir, actually, any Doppler, when we put the Doppler, any valve, any like mitral tricuspid, wherever, the peak velocity is the maximum velocity throughout during the measurement, and the peak gradient is also the maximum gradient throughout during the measurement, and mean is total average of the both mean velocity and gradients are the average of the velocity and average of the gradients.
Good, very good. So how do you get peak and mean velocity in a Doppler spectrum flow? Look, I have shown you a Doppler spectrum flow over here.
Yes, sir.
So how did you
It's
get
an
this?
LVOT.
Yeah, how do you get this peak velocity, mean velocity? How do you get all this?
It is there in the picture. What have they done?
Whenever I tell you the
See, they have done something with the green line. What have they done with the green line?
Hello?
Hello, can you hear me?
Sir,
see the
no,
fourth
sir,
complex.
again, please repeat, sir.
See the fourth complex from the left side.
Hello?
Can you hear me?
You
can't hear me?
Yes, sir.
Hello.
Yes.
See
Yes,
the
sir. I hear you, sir.
See the fourth complex.
But I can't get your question actually.
Can you see the picture?
Sir. 1, 2, 3, 4. Yes, sir.
What have they done to the fourth complex? They have traced out the fourth complex. Haven't
Yes,
they?
sir. Fourth complex. Yes.
And by tracing out, you can get the peak velocity and the mean velocity, and also the VTI.
Yes. Yes.
So why you're not able to say this? This is very simple.
All right, good, Chandan. Dr. Yogesh Namdev Patil, absent. Majrul Islam.
Yes, sir.
What do you mean by VTI?
Sir, velocity time integral.
This is 16.9 centimeter. What does you mean by 16.9 centimeter?
$16.9. No, sir.
Okay, where do you use this VTI in day-to-day practice of echocardiography?
Sir, to measure the sir valve area, sir. Valve area in case of mitral stenosis or aortic stenosis.
Mitral stenosis, we measure valve area by planimetry. Aortic stenosis, we measure valve area by continuity equation. Where do you use VTI? And this is a live example for aortic VTI, aortic valve area. So why do you use LVOT VTI in aortic valve area? Wait for a minute. Somebody else, I'm going to ask you the next person. Don't go away. Majrul, this is very important VTI is. Dr. Nida Fardeen?
Yes, sir.
What do you mean by VTI, velocity time integral? Where do you use VTI and what does it mean by VTI?
Sir, we have to envelope the gradient to get the LVOT VTI, which will give you a peak and mean gradient, and it is used to calculate aortic wall area, where aortic wall area equals to LVOT VTI into LVOT area upon AV VTI. will give you aortic wall area by continuity equation. We can also use it in stroke volume also.
Perfect.
Wherever, yeah,
Perfect.
wherever
Perfect.
we want to give, use the VTI and the cross-sectional area over that thing, you will get the stroke volume of that particular wall.
What do you mean by 16.9 centimeters, Pradeep? If you give me this question, I'll be really happy.
How do I get the 16.9?
No, what do you mean by 16.9 centimeter? Velocity time integral is a formula with which it tells you how much the blood has traveled to a certain distance with every stroke. That's why we say in 16.9 centimeter. Thus, distance traveled by blood at that particular point with every stroke is known as VTI, velocity time integral.
Yes. So
Yes,
sir, yes. Peak gradient जितना है उतना ही होगा आपका VTI ना?
नहीं, ऐसा नहीं होगा. Peak gradient अलग चीज है, VTI अलग चीज है. Anyway,
it is the distance traveled by the red blood cell.
Yes, towards the probe है क्या sir?
Towards or away, whatever it is.
Away from the probe, sir. The
Right.
blood. Yes.
Good answer, Pradeep. God bless you.
Sir, Farheen.
Farheen, right?
Yeah. Yeah.
Nida Farheen.
Yeah.
Okay. I have written Nida Farheen Ayub Khan.
Yeah.
Perfect.
Thank you, sir.
Last is Dr. Sai Prasad. Yes, Sai.
Sir, I'm here, sir.
Sai, tell me what is the normal LV wall thickness?
Normal LV wall thickness. It's I read it, but I don't remember.
No problems. It's about 12 millimeter.
Yeah, 12, 10 to 12. 10
to 12.
millimeter.
When do you call LV hypertrophy?
When it is more than 20 mm, sir?
More than 12 millimeters. It's a very variable things. Americans believe anything more than 10 millimeters. Indian believe more than 12 millimeters. And some people believe more than 15 millimeters. So it's quite variable. So anything which is more than 12 is considered as hypertrophic. Right?
Okay.
Last question to you is, when do you measure LV wall thickness? During systole or diastole?
It's in systolic, sir.
Oh. It should
No,
be
sir, it's in
diastole.
diastole. I'm sorry.
Diastole.
Diastole, I'm sorry,
Systole will be
diastole.
thickening already.
Yeah, correct. I'm sorry. It's in diastole.
So always
in the resting
measure in
phase.
diastole. Good, great. Take care, all the best. Sai.
Thank you, sir.
Last, Dr. Clay from Tanzania. Clay, are you there?
Yes, sir. Can you hear? Yes, sir.
Yes, I can. Atherosclerotic aortic valve. What is the velocity in atherosclerotic aortic valve?
What's that, sir?
If somebody has got atherosclerotic or aging aortic valve, what will be the velocity?
Velocity for aortic.
Aortic. If aortic valve is thickened due to aging process, what would be the velocity? Okay, what is the normal velocity?
For aortic.
For aortic.
Aortic valve. What is the normal peak velocity?
I don't know, 2.6.
A while ago. No. Mitral and aortic.
1.7, right?
Mitral is 1.3. Aortic is 1.7.
Yeah, 1.7.
Half of aortic is pulmonary, that is 0.9, and half of mitral is tricuspid, that is 0.6. Would you repeat that, please? Mitral is how much?
Mitral is 1.3.
And aortic?
1.7.
And half of aortic is 0.9, that is a pulmonary, and half of mitral is 0.6, that is tricuspid.
Tricuspid, yeah.
So if you have an atherosclerotic aortic valve, your velocity will go up. And it is said to some extent that velocity up to 2.5 meter per second is considered as atherosclerotic aortic flow velocity. Now this parameter is not right to a large extent. Now we are seeing many people who have got significant aortic stenosis because of atherosclerotic valves.
Yes, sir.
So 2.5 leading to a gradient of almost 25 millimeters of mercury was considered as atherosclerotic aortic valve. Dr. Clay, the last question to you is, where do you keep sample volume for aortic valve?
You keep it.
Do you keep it in
sample
India?
volume, right?
No. Do you keep it in India or do you keep it in Tanzania?
No, and see, sample volume you keep it under.
Under where? Under the roof, under the umbrella?
Under the aortic leaflet.
Any valve, keep it at the tips of the open leaflet.
Clay, read, man. Whenever we talk of aortic valve, just distal to the tip of the leaflet or in between the two leaflets.
Okay, in between two leaflets. Sorry, sir.
And LVOT?
From aortic. From aortic.
In LVOT is a left ventricular outflow tract. So we have to keep it at LVOT or aortic annulus.
Aortic annulus, yes.
Right?
Aortic annulus. Yes, sir.
Great. So don't forget, read it. Definitely.
Yeah, aortic annulus. Yeah.
All right. So I think we have done reasonably good. Questions, Abhijit, is 9:45. And anybody would like to ask any question before we close down this session today? Now it's a reverse thing. If somebody wants to clear his or her doubts, they can ask. Me and Abhijit are there to answer your questions.
Sir, I want to ask one question.
Jaising, go ahead.
Sir, in apical two-chamber view, if I have made some good four-chamber view, after that I rotated the transducer, but sometime I am unable to see the anterior wall basically in two-chamber view. Then what should we have to do for best optimization to see the whole anterior wall?
It's a very simple thing, Jaising. When you have got a four-chamber view and rotate, you can't get two-chamber view is go a space down.
One space down. Okay, sir.
Yeah. Then ask the patient to take a deep breath.
Okay.
Your fourth chamber will become clear and then rotate the probe to counterclockwise.
Okay, sir. Next time
Try
I will
this. Try this. It'll be very helpful to you.
Okay, sir. Right, sir.
That's
Thank you,
how
sir.
we get a two-chamber. Your question is very valid. It means you're doing echocardiography. We do have this problem number of times when we can't see a two-chamber view very well.
Okay, sir. Thank you,
Four
sir.
would be easy. Three would be easy, but two will not be easy.
Yes, sir. Yes, sir. So sometime I have missed LAD territory. So
Yeah, just go
that's
down
all.
a space, ask the patient to take a deep breath. Your two-chamber will be very clear.
Right, sir. I will try this.
Okay,
Thank you,
great.
sir.
Anybody else?
Sir.
Nida,
Yes, sir.
Farheen, Ayub Khan.
सर मेन पल्मोनरी आर्टरी प्रेशर वापस से बताएंगे क्या टीआर जेट का अर्ली डायस्टोलिक एंड लेट डायस्टोलिक
PR jet ka?
Yes.
Look, Nida, when we have a PR jet, if you look at a PR jet is along with whole diastole.
Yes.
So it will have early diastolic peak and a late diastolic peak. Early diastolic peak, suppose this is correspond to mean pulmonary artery pressure. Suppose it's 2 meters per second, 2 into 2 into 4, 16, plus RA pressure, that'll give you mean pulmonary artery pressure of 21.
Yes.
Late peak, suppose it's 1 meter per second, 1 into 4 will be 4, plus RA pressure to it, it will be 9.
9.
That is LA pressure, LA mean pressure. In this, there is a condition that should not be any lung problems.
Okay, sir.
Then it become haywire.
And that formula is 0.62 into.
Okay, that is not for PR. That is for TR jet velocity. Suppose we are getting a tricuspid regurgitation velocity. The peak velocity is 3 meters per second.
Yes.
3 into 4.
9, 4, 9,
36.
36.
Then you add RA pressure to it, 5, 41.
5, 40.
For calculation, 41 is a peak pulmonary artery pressure. For calculation mean, you get 41, make it to 40, 40 into 0.6, 24, add 2.1 to it, 26.1. That will mean pulmonary artery pressure. Anything more than 25 is considered as abnormal.
Abnormal. Thank you, sir.
Anybody else?
Hello, sir.
Yes, go ahead, Majrul.
Sir, I have a question, sir.
Go ahead.
Sir, what is AV cast separation and E point separation? This
AV cusp separation and E point septal separation. AV cusp separation is atrioventricular complex, like mitral valve cusp separations or aortic valve cusp separations.
Yes, sir.
And E point septal separation in Plaque's window, if you put an M mode across mitral valve, when the mitral valve opens, the tip of the mitral valve, when it opens, the distance between E point and septal is known as E point septal separation.
Yes.
And this E point septal separation is at one time when we did not have 2-dimensional echo, it was very useful parameter for LV dilatation.
Yes.
Normally 7 millimeter, it gets more than 7, then we start suspecting LV dilatation.
Yes. Sir, one more, sir. D separation and EF slope, sir.
D excursion.
Yes, sir.
When the mitral valve opens up, this is known as DE excursion, opening of the mitral valve, 15 to 26. EF slope is 50 to 150 millimeters per second. These are the parameters when the mitral valve used to be stenotic. At that time, we used to write these parameters that D excursion is reduced and EF slope is also reduced.
Yes, sir. Okay, sir. Thank you, sir.
Thank you. Anybody else?
To measure the LV wall thickness, do we use M mode for that or 2D usually?
Good question, Dr. Balram. We always use, preferably, like what I do in my practice is I always do a cut M mode, just distal to the tip of the mitral valve leaflets in Plaque's window. And then we do leading edge to leading edge of septum, leading edge to leading edge to posterior wall. Abhijit, your comments.
Absolutely right, sir. Agreed.
Thank you.
Anybody else? All right, Abhijit, your final comments before I'll close down the session.
Sir, we have had a wonderful session. I think the dinner is getting close. I mean, it's getting cold. So let us close this session and have dinner.
Okay.
Thank
with
you.
these few words, let me pay thanks to Dr. Prj Chatterjee for
Thank you.
excellent cooperation and asking these questions. And thanks to all delegates, their husbands and wives who have been straining for a long time to have their dinner together. So respected husbands, respected wives. So you can have your husband and wife out of this class to join you with the dinners.
Thank you very much.
Thank you. Good night.
Thank
Bye-bye.
you, sir.
Good night.
Take care.
Bye.
Stay safe. And this will be there on our website to listen to you again and again.
Thank you, sir.
Thank you.
Thank
Good
you,
night.
sir. Good night, sir.